Hello, everyone, and welcome to the presentation for today. I'd like to introduce Dr. Ariel Freda. So go ahead and take it away.
Okay, so can you hear me? Okay, perfect. So I wanted to see how many people we have now here.
15.
Oh, okay, perfect. So let me just put this so I can see. Okay. So I'm Ariela Freda. I'm a perinatal psychiatrist. I work at Frontier Psychiatry, and I'm the medical director of Prison for Moms. And I'll mention it later. It's a consultation line. If you have any questions about your patients, you can call us. But this 3D echo, it's about perinatal mental health. Today we are going to do the session number 2. It's a 10 series sessions, and we are going to talk about the management of depression during the perinatal period. So before we start, I wanted to see if we sent an email asking for a case, if anybody has any case that would like to present, because the way we will do it is that we will talk about it, and the panel will discuss the management of depression during the perinatal period, but then we will discuss a case. So if you want to start thinking about it, and if any of you has any case that would like to bring up, it's okay, it doesn't have to be formal. You can just discuss it with us here. So I'm just bringing up, so if anyone has any case when we get to that point, I can ask and you can present it. So I have here with me Mary from Mountain Pacific and Amber, and I have Bree from Happy Mothers, Happy Babies, and a Healthy Mothers, Healthy Babies, I'm sorry, and Megan Fallon, who is a psychotherapist in Montana and a perinatal therapist. So we will be presenting this topic today. So before we start, I wanted to do a poll. Actually, this is related to the last session, to see what you think about it. So based on your knowledge so far, how frequent are perinatal mood and anxiety disorders? So let's see. Okay, so it seems that, can you see the results? Can people see the results? Yes?
Yeah, we can see it.
Oh, okay, perfect. So it seems that we are all on the same page mostly. It's 1 in 7, perinatal mood and anxiety disorders, the frequency. And actually during the pandemic, it has been more, 1 in 5. So I just wanted to kind of start by sharing this with everyone. So stop sharing. What do I do? Should I just click out of it? Okay. So I will go ahead and talk about what we have to talk, and then I will stop sharing my screen so we can see each other and we can have a conversation about all this.
And Ariela, one of the things I put, and first of all, I'm so sorry I'm late. Do you mind if we just start real quick with introductions?
Yes,
I'm so sorry.
Sure. Let me see. Do you want to stop sharing the screen? Because
yeah, go ahead and stop sharing. And let's see, I'm gonna go to gallery view. Okay.
Yeah.
Cool. Thank you. And again, I'm so sorry I'm late. I'm a terrible human being. So Yes, so I'm Eric Arzubi. I'm here with Frontier Psychiatry, and this is our second session of Project Echo for perinatal mental health. And all of you have already been listening to Dr. Ariella Freda, who is the medical director for this clinic. Just keep in keeping with the spirit of Project Echo, we'd invite, insist, and if I could, force everyone to leave your cameras on. I don't care if you not wearing makeup. I mean, I'm wearing makeup today, but if you guys aren't, that's okay. And again, this is just to keep it as interactive and as possible, and to increase the amount of connection we can build here among everyone, and creating a safe space to learn. What I would like to do is start off first with kind of introducing the panelists, the hub of this clinic. Again, Dr. Freda, please, if you can say hello, and then we'll introduce everybody else.
Yeah, I introduced myself. Yes.
Oh, perfect. Sorry. Oh, yeah, that's right. I was late. And then how about Bree?
Hey, everybody. I'm Bree McLaurin. I work for Healthy Mothers, Healthy Babies as executive director, and I have a lot of experience in perinatal mood and anxiety disorders through training and also personal experience.
Thanks, Bree. Megan?
Hi there, I'm Megan Fallon. I'm an LCSW in Billings. I have a private practice, and I have been working with families and moms for almost 10 years, but I've been in the perinatal field more so for the last year to 18 months after my own experiences with a difficult pregnancy and childbirth and postpartum experience.
Thanks, Megan. And Megan's also like cranking on this Facebook page. You want to tell everybody about the Facebook page?
Yeah, so I can't take all the credit. Bree needs a lot of the credit too. But we are, so I'm not sure how many people are in there's a Montana Mental Health Facebook page, which is an awesome resource where I think there's almost 1,000 people in the group across the state of Montana, where we are often like sending referrals and resources and information, and if we have questions for one another. And so we're trying to get something similar going for perinatal mental health. And so I looked this morning, I think we're up to like 80 members so far, which is pretty exciting. And we just envision this a space being for providers and all sorts of providers, mental health, medical providers, nurses, midwives across the state of Montana, just to collaborate, share resources, share information, share referrals. So I'll post the link. Bree already posted the link in our chat box.
Bree beat you to it.
Yep, she sure did. Shocking.
But that's awesome. I think like 2 weeks ago or 3 weeks ago, there were only like 10 members or something, and now like hey, that's pretty awesome. So yeah, that's great.
Exciting. Yep.
No, yeah, and please use it, because that Facebook page for Montana mental health professionals has turned out to be like one of the better mental health resources I've found in the state. It's pretty amazing. Well, great. And then
I can
folks,
post a link to the Montana mental health in general too, if people are interested.
Yeah, go ahead and do that. That'd be awesome.
Okay.
Thank you. Amber with Mount Pacific, would you like to say hello and your role here?
Yes, Amber Rogers with Mountain Pacific Quality Health, and I help with some of the background stuff, and we will be having CMEs for this. The application's been sent. It's just going to take us a little approval time, and so we're happy to help support those continuing education credits.
Thank you, Amber. And then Alona? Is Alona on?
No, it's Mary.
Mary.
Hi, Mary Argonis. I'm your project support, IT support from Mountain Pacific.
Great. Thanks, Mary. Sorry about that. I'm glad I'm hosting. So let's see what else. And of course, Mount Pacific being the partner that's helping to really make this 3D echo possible with Frontier Psychiatry. So let's go through and just do some quick introductions. And thank you for those of you that turned on the camera. This is much more inviting than looking at black screens with names. How about Chelsea Solberg, if you don't mind saying hello, introducing yourself and where you are, what you do.
Hi, Chelsea Solberg. I'm from Central Montana Medical Center in Lewistown. And I work here I wear a couple different hats, but I work closely with our doctors, following people for prenatal education and postpartum support and lactation.
Awesome, thank you. Lewistown in the house. Cassie.
Yeah.
Hi, I'm Cassie Bronson. I'm in Missoula, Montana. I'm a women's health nurse practitioner student, and I am doing my dissertation work on substance use identification in pregnancy. So learning hand in hand about perinatal mental health. So thank you.
Awesome. Thank you. West Coast in the house. I guess kind of west, right, Missoula? How about April?
Man, I had to do it last time. I thought I was getting out of
You
it.
did? I didn't
It's
keep
okay.
a
No,
list. I didn't keep a list. I don't know.
It's all good. I'm April Quinlan, and I'm in Mineral County. I serve as a parents as teachers supervisor, early childhood grant supervisor, but then also I'm finishing my license as an LCPC, and really focusing in on women's health in general, but specifically working with postpartum mamas and all of that. So
Awesome. And where are you located?
everybody. Mineral County, so Superior, Montana.
Okay. Oh, so you're Superior. That's good.
Yeah.
Montana in the house. All right, Naz.
Hi, I'm in Billings. I'm a counselor with the Midwifery and Women's Center. Nice to meet everybody.
Thanks for joining. Darcy.
Hi, I'm Darcy Fairchild. I'm a LCSW in Missoula, Montana, and I specialize in working with perinatal mental health. And yeah, I'm excited to be here with y'all. Thanks for putting these on.
Of course. Thanks, Darcy. Sarah Beth.
Hi, everyone. My name is Sarah Beth Upson. I'm the Perinatal Behavioral Health Initiative Program Officer with Montana DPHHS, based out of Helena.
Thanks, Sarah Beth. And it's her purse that's letting us do all this. So thank you. Thank you, Sarah Beth. Jenna.
I'm Jenna Willis. I'm an SWLC. I have like 10 more hours and then I get to take my test. I'm up in Whitefish, Montana, and I just finished with Alta Care for the year, and I'm transitioning into private practice to work perinatal mental health.
Awesome. Thanks for doing that. Good luck. See, but you got a lot of people have your back, so you're good. Stephanie.
Hello, everybody. I'm Stephanie Morton. I'm the program manager with Healthy Mothers, Healthy Babies, and I'm based out of Three Forks.
Thanks, Stephanie. Next up, I'm gonna pick two more, and then we'll get cranking. Emily Marks.
I'm Emily Marks. I'm in Gallatin County, and I'm a home visiting nurse here through our health department.
Very cool. Thanks for joining. That's kind of cool. One day you got to tell us all about the stuff that you see at home. Because that's got to be a completely different perspective, right? Doing work in the home versus kind of hanging out in the clinic where everybody gets put on a happy face or some kind of face. Yeah.
Absolutely.
Awesome. Mandy Reinhardt.
Hey, everybody. I'm the care coordinator here at St. V's Midwifery and Women's Health.
Great. Thanks for joining, Mandy. Cool. All right. It's enough me talking. So Dr. Freda is going to lead us in the didactic. And then after that, we'll do a little bit of Q&A, and then we'll go into one of the cases. So please, thank you, Dr. Freda, and everyone.
Sure. I want to make an announcement before I start. There will be a SurveyMonkey later today. You will receive it, so please complete it. It's about questions about your comfort with treating these patients and how do you feel about referring these patients. So just if you can complete it, it will be great. Okay, so let me share my screen. Okay, so we made a poll and most everybody responded. What we know is that it's 1 in 7. That's great. So I wanted to kind of get some information from the last session to see if people learned about it. So let me, 1 second. Okay. So this I also mentioned last time, but I think it's very important as we talk about management of perinatal depression is to talk about how women that stop their psychiatric medications during pregnancy have a high chance of having a depressive episode. while women that continue their medication also have a chance, but as you see, it's much less. So if you stop your medication, you have a 70% chance of having a depressive episode, while if you continue it, the chance of having a relapse is 26%. And usually pregnancy is a major reason for women to stop their medications. And sometimes it's because the providers actually don't give them a prescription for it. So in terms of management of depression during the perinatal period, the most important thing, and what I want you to get from this, is that women should feel well and be okay during pregnancy to improve the outcomes. That's the most important thing. And no decision is going to be risk-free. There's going to be risk of the illness, and you need to weigh it against the risk of the medication and the treatment. And the risk assessment is individualized. So it's not that one medication or one treatment will be for everyone. It's that every patient is different, and we need to have in mind their past history, their current symptoms, their medical history, if there is any substance abuse. We have to put all that into our account and decide what's the best treatment. And when you choose medication, you're always going to use the medications that you have more reproductive safety data. This is very important because usually when a medication comes out, it seems that it's fine when it's a new medication, because we don't know enough about the medication. That's why we don't know any negative effects of that medication in reproduction or on the babies. But so it's always better to have a medication that might have some negative effects, but we know what are the negative effects, instead of using something new that we don't know about. And we always try, as psychiatrists, we always try to use the least amount of medication possible. But as I said, it's possible. If it's not possible, you might need to keep the woman in the medication she's taking. So very important to encourage participation in prenatal care and avoid any unhealthy habits like substance abuse. This will help to improve the outcomes of the pregnancy. Always try to involve somebody that the woman, that is important for a woman, either a significant other or family member, somebody that will help her during the pregnancy and the postpartum, but also who will help you identify if the woman needs help. So I always try to involve the significant other and bring them at least to one of my sessions to discuss how the woman is doing and what are the red flags, what to look for. If I'm concerned about the woman, what do they need to look in the postpartum, so they can be involved in the treatment. I always like to discuss the goals of treatment so we are on the same page and the woman knows what, and I know what she wants and she knows what I'm suggesting. So I think that's very important. Always try to reduce any stressors, help her go through what are the stressors and what can be reduced and what can't. And I always discuss treatment options, including individual and group psychotherapy, and we'll talk more about that. And there are options about medications, and then for women that are more severe, there is ECT, TMS, and brexanolone that are other treatments. So if you have any questions, please let me know, you can interrupt. So I always start with preconception because that's the best moment to find these women, you know? Like when you have somebody that is not pregnant and comes to you and tells you, I want to get pregnant, that's the best because you can make any medications changes that you need to medications that have more reproductive safety data. You can plan in advance in case there is a relapse or if the woman gets very sick, she can participate in the decision what will be the best for her. And also it gives you time to involve the family member. So the consensus is that women should feel well and be okay during pregnancy to improve the outcome. And for this, you need to screen and treat them ideally prior to pregnancy. So when we think that somebody, let's say we already identified a woman and we think she has depression and we are ready to treat them, you know? So what we need to do first is to screen for bipolar disorder. And why is this important? Because the treatment will be different. Because if one of the reasons, if you give a treatment that is just for depression, like an antidepressant, to a person with a bipolar disorder, you can trigger a manic episode. So you really want to make sure you know if this patient has bipolar disorder, and if that's the case, treat it or refer the patient to somebody else that knows how to treat it, so she gets the best treatment possible. And ways of screening for bipolar disorder is just asking several questions. So you want to ask the woman if she has been feeling much more excited and full of energy than usual, if her mind goes too fast, if she talks a lot, if she feels restless or unable to sit, and if she's doing things that are not usual for her, like driving too fast or spending too much money, and if she had periods of like this for several days or longer. And you will also ask, because one of the symptoms of bipolar is feeling more irritable or angry and getting into arguments, hitting people, throwing things, breaking things. So you also want to ask about that. And if any of these questions are positive, you will ask a little bit more. And you want to ask how they sleep, if they have all these symptoms at the same time, you know, if they have buying space, if they're behaving in ways I would normally think are inappropriate to them, if they're very restless. And if you find somebody that might be bipolar and you have more questions about it, or you are unsure and you want to refer them to us for questions, you can call Prison for Moms and we will help you with the management of them. So, as I said, it's an individualized treatment for each woman. And women with less severe symptoms can do well with just psychotherapy. But women with more severe symptoms or a history of a previous postpartum episode, or if they have recurrent illness, they might need both medication and psychotherapy. And I always try to stress the importance of psychotherapy. So that's it's not just medication, like if medications can do so much, but the psychotherapy part is very, very important. And I wanted to ask Megan if she wants to tell us a little bit about psychotherapy.
Sure. Yeah, thanks, Dr. Freda. So I'm just going to talk for a minute here on some of the main components of counseling with postpartum women and their families, and then some of the current evidence-based therapies out there. So there tends to be some common themes when we're working with mamas in the postpartum period. A big one is just change in identity. So including any identity shifts, any expectations, any losses maybe that these moms have experienced as a result of this new role that they're in. There's often a lot of perfectionism that comes out, issues with relationships, role conflicts, self-esteem, self-worth. There's a lot of focus on self-care and just being emotionally overloaded. So first and foremost, you know, with therapy, when I've got a mom come in, I'm looking at kind of this triangle of sleeping, eating, and even kind of movement, because we know above all, I think that's one of the most important things to be thinking about. And then looking more into a specific therapy model, CBT, cognitive behavioral therapy, and IPT, interpersonal therapy. Those are the two most researched and most validated treatment models right now. You know, cognitive behavioral therapy, we're looking at our thoughts, feelings, and behaviors and how these are impacting mood. A lot of times moms that are struggling with postpartum issues, there's a lot of negative and irrational thoughts that are occurring. So we work on identifying those thoughts, challenging those thoughts, reframing them. And then if we can get the mom thinking in a little bit more rational manner, that tends to help with symptoms. And then with interpersonal therapy, this therapy approach looks more so at attachment, role transitions, expectations, communications issues. And you know, oftentimes this can be utilized with a partner as well. And so trying to, like Dr. Freda had talked about, incorporating the partner in some of the medication management appointments. Anytime we can utilize a partner, especially with interpersonal therapy, that can be really helpful just because that additional support is so huge. There is some emerging research right now on EMDR and the use of on birth trauma as well. So that would be something I would recommend. And then you need like peer support or group therapy. And I know right now in the age of COVID, I think we're a lot more limited, but PSI, Postpartum Support International, has, I think, about a dozen virtual groups going right now. And these moms can log on to these groups. I'll post a link for the postpartum. It's just postpartum.net. And these are peer support groups for moms all over the country, all over the world, actually, that they can engage with.
Thank you, Megan.
Yeah.
So, as I said before, when you think about how to treat these patients, you need to remember that you have two patients. You know, you have your patient, the mother, and the fetus. And you need to put it in a balance and see what is more risky, if it is the risk of the untreated illness or the risk of medications when you decide what medications to use. So when giving a medication, you need to think about 5 things I put here. I always remember that I need to put the 6th one, and I'll tell you which one is it. So any risk of miscarriage, any risk of malformations, any perinatal complications, any effects on the newborn, long-term effects of the medications on the child, and also breastfeeding, if the woman wants to breastfeed. So even if they tell you, I don't want to breastfeed, and no, I'm not going to do it, it's important to keep that in mind because the woman can change her mind. And it's very important about this is that it's important to put it in how relative it is. Like, you need to know that there are risks for women that don't have any mental illness of risk of malformations, risk of miscarriage, perinatal complications. So it's important for the woman to know that even if she doesn't take medications, even for women that don't have mental illness, there is a risk in the general population. So it puts it into perspective, the risk of the medications. So we have a poll here, and I wanted to know if you have any thoughts about which antidepressant is contraindicated in pregnancy. So sertraline, paroxetine, bupropion, all of the above, or none of the above. So what do you think? Anyone else wants to vote? Okay. So most of the people put that paroxetine should be contraindicated. That was 54%, then 23% bupropion, then 8% all of the above, and none of the above, 15%. And actually the answer is none of the above. Thankfully, there is no antidepressant that is contraindicated in pregnancy, and we'll talk more about it. Move. So what is important to know is that all psychotropic medications cross the placenta, and none have been approved by the Food and Drug Administration for use during pregnancy. We have now one drug that is approved for use on postpartum, that is brexanolone. It's a new drug for postpartum depression, but during pregnancy, there's no drug that has been approved. So when we use these medications, we use it based in experts review, in the research, in the available literature that we have. So, but the FDA rating, it's really doesn't reflect the available data. It's very slow to adopt revisions. And so I really don't use it. When I need to know something about a medication, I go and I search it up and I search what is the literature saying about it. Because this FDA rating has been used for a long time, but it's really not helpful. And like new medications might be a category that says that there's no risk, but it's more because we don't know about them. So it's important to know that it's really not helpful. And women will come and will tell you, oh, I don't want to take this medication, it's class D, or I don't want to take this, it's class C. And the reality is that it's not really helpful. And actually the FDA changed the labeling. And now they have a new labeling that is like a summary that they provide with risks and clinical considerations and data during pregnancy and lactation of new medications. But the old medications will be reclassified over time. And they also have a section about females and males of reproductive potential, which is really helpful. So it's important to tell the woman that no decision will be risk-free, even if you take medication or if you are keeping yourself depressed. Both scenarios will not be risk-free. SSRIs, that are these medications like paroxetine, sertraline, citalopram, are all are the best studied class of medications during pregnancy. And we'll talk more about it. But when you decide, you really need to think what options you have, and you need to consider all the options. So as I said before, if somebody has a case of mild depression and can be treated by psychotherapy, you might try to use that first. So the risk of antidepressants, there are a lot of studies out there actually about it. Studies are not perfect because we can't do double-blind randomized control studies in pregnancy for ethical reasons. And some studies suggest that there is a small risk of malformations with paroxetine. But actually, if you read the studies very well, you see that this is inconsistent. And there are more new studies that suggest that actually the risk, even with paroxetine, is not more than in the general population. There was, initially they saw that paroxetine was associated with cardiovascular malformations. And now we know that actually the risk, as I said, seems to be the same that in the general population. So the most of the evidence doesn't suggest that there is birth complications with these medications. And the studies that we have in long-term effects on children are very reassuring. Actually, they compared women that took medication in pregnancy to women that were depressed, and they saw that the children of mothers that were depressed had most negative effects like lower IQ, behavioral problems, feeding problems, and they were more prone to be depressed themselves. And this is the only thing that you will see mostly, and it's not very common, not at all. It's at the most 15%, but some babies can have a transient neonatal symptoms, which is called adaptation syndrome. This is seen also in the general population and with other medications. So it's not just antidepressant, but what you see is for a few days, the baby can be a little colicky, irritable, have feeding problems, sleeping problems, but it goes away. It doesn't last more than a few days, not more of a week for sure. So I want to remind everyone the risk of no treatment of depression during pregnancy is the risk of postpartum depression. And with that, all the negative effects that postpartum depression can have, it can have a difficult time with the bonding of the mother and the baby. The mothers can have a harder time taking care of themselves and the baby. They can be very anxious, and that can affect them. And there can be birth complications associated to untreated depression. So it's not something to take lightly and say, I'm not going to treat, you know, like I'm just let them be because I'm concerned about a medication. So the other thing I wanted to mention is what happened with antidepressants in breastfeeding, you know. So the antidepressants that we use the most are the SSRIs and SNRIs that are the, as I said, paroxetine, sertraline, escitalopram, citalopram, then SNRIs are venlafaxine, that is Effexor, Prestic, Cymbalta. So all these medications are the ones that we use as first line. Why? Because they are non-sedating, so it's good for the postpartum. You know, women will not fall asleep while taking them. They are well tolerated, and they're very good for the comorbid anxiety and obsessive symptoms that women can have. And the good thing is that if they want to breastfeed, that was one of the things I was mentioning, sertraline and paroxetine are low or undetectable in the baby's blood. And they can have some negative effects, but they are usually very, very infrequent. And as you see here, increased crying, decreased sleep, GI distress, irritability. And we have some small studies but about long-term effects, but there's no real negative effects, but we don't have enough information about that in the long run. So what I wanted to say basically is that what I think is the most important point that you need to remember is that mood disorders are very prevalent in pregnancy and postpartum. They can be associated with negative effects if not treated, and they can affect the relationship of the mother with the baby, which is very important. Women that have a history of mood disorder need to be informed that they have a high chance of relapse if they stop their medications. You'll see that a lot of them stop their medication, and sometimes it's because their doctors told them to do it. And that's very, it's not good for them. Then, as I said about preconception, if you are going to do any changes in their medications, you should do it prior to pregnancy, because that will give you time to see if the woman tolerates that medication and if it's working well, and you are not going to expose the baby to more medications. And you always consider other options before starting medications like psychotherapy. We said you will use medications that you have more information in reproduction about them. And very, very important to remember, antidepressants are not major teratogens. They are not drugs that cause malformations in a level of other drugs. You know, actually we can really debate it because there are a lot of studies about it, and they don't seem to cause malformations above of the general population rate. So no decision is going to be risk-free. That's very important. Always, always consider mental illness as an exposure. So you need to limit the number of exposures. And this is very important because if you start a medication and you start at a low dose and the woman is still depressed, that means the baby is exposed to two things, the mental illness and the medication. So if you're going to start a medication, you need to start it and go higher and use the dose that you need to use so the woman doesn't have her symptoms. Always consider breastfeeding when you're planning a treatment because it can guide you in terms of what medications to use. Always collaborate. That's so, so important. As a psychiatrist, it's so important to collaborate with the therapist and the obstetrician, the midwife, then the pediatrician, because I think the most important thing is not just to know what's going on with the patient, but also to have a common message that we give to the patient. Because if I tell the patient a medication is okay, but then the obstetrician says something different, it can cause a lot of confusion. So it's better to always collaborate. And as I said, it's an individualized risk, benefit, and decision-making process. And every patient is unique. So thank you for listening. Now we are going to discuss, first of all, if you have any questions, please, about this material. Yes, Darcy.
Hey, Dr. Freda. I was just, I was typing it in, but I'll just ask quickly. I was wondering if you have any thoughts on how we can better incorporate pharmacists into the conversation. I've heard recently, within this past probably 3 weeks, of 2 different cases in Missoula where a mom will go to fill her prescription and be shamed essentially by the pharmacist. and then start, like questioning and second guessing her choices. And in the worst case scenario, one mom chose not to fill the prescription. So that's just something that's been running through my mind. And I'm curious if you have thoughts on that.
Thank you for bringing it up, because I have the same problem and I get so upset about it. Like, you do all the information, you give all the information to the patient, and then they go to the pharmacy and the pharmacist says, no, you can't take this medication, or this is really bad for your baby. And then it's like all your work, it's going, like it doesn't help, because once my take is that once somebody tells a woman that the medication is risky, she might not take it, very likely. Even if you go and you give her all the data, she might not take it. So I totally agree. And what I have been doing is, when I'm presenting with these kind of situations, I call the pharmacist and I tell them, I had a conversation and I try to educate them. But that's really a good point, how we involve pharmacists in all this, because they are the first person the patient sees sometimes when she picks up the medication. And if they get a negative message, it's very problematic. Thank you for the question.
Yeah, thank you.
Any other questions? So I wanted to discuss a case. Yes.
I just have a quick thing. Perhaps it would be helpful if we did a little outreach to the Pharmacy Association to invite them specifically to this meeting, because so much of this is going to be medication support. And so I think I might be able to figure out some people from the School of Pharmacy here in Missoula, that perhaps we could kind of get the word out, or even see if there's students, because it's easier to train people to begin with than it is sometimes reversing practice patterns that have already been established. And so I will go ahead and shoot this email, the invitation to this series to the pharmacy program here. And if anybody else has contacts, I think that would be a good thing for us all to consider. So I'll find the link that you all can share with any of your pharmacy contacts. How does that sound?
I think that's a great idea. Thank you, Amber.
Hey, Amber, I also, sorry, I wonder, maybe mentioning to Tony, Tony King,
oh yeah,
he might be able to.
That was email going to be email number 2.
Gotcha. Yeah. So Tony King is there. I guess he's like what's his role there? I mean, I know he's a senior pharmacist, but what's his official role?
Yeah, he's the pharmacy director for Mountain Pacific has a division that does drug utilization review. I don't know what he does.
Yeah. Yeah. No. That's right. So yeah. So he's
for the Medicaid.
For Medicaid, right? So basically, what's kind of cool is Mountain Pacific helps Medicaid Medicaid insured population. They approve or not approve medications that are recommended. In other words, what's nice is Mountain Pacific has really good ability to reach out and perhaps help us with education around this issue. So that's really nice. So thanks, Amber.
Or Dr. Zuby, what about Michelle Reinhardt? Is that her name? At Billings Clinic, the psychiatric pharmacist at Billings Clinic. Would she be a good resource too?
Should be a wonderful resource. Now, ironically, she just gave birth. So
I heard that. Yeah.
Yeah, and actually, So she'll be perfect. And now, as a mom, she could speak to this as well. Mm-hmm. So this is so it's perfect. That's a great point. I also wanted to just bring up just a couple quick things. Number one is reminding everyone that maybe I was kind of incorporate a slide or something, just to want to make sure everybody knows how to reach the PRISM line when it comes to asking questions and getting a consultation, right? So you can either go to prismconsult.org. So it's prismconsult.org. And there you can get the information for how to reach out by phone or submit an e-consult, basically filling out a quick form with a clinical question. And then Dr. Freda will be the ones fielding those questions. And also, we have the opportunity for particularly complex cases for us to do a one-time face-to-face direct consultation with the patient. So we, and in fact, I believe Dr. Freda just received a referral for our first one. So please, by all means, use this resource. I think it can be helpful. And then there also, if anybody has questions on some of this, there are lots of screening tools that might be helpful too. It might be helpful for, Dr. Freda was mentioning screening for mania. There's a mood disorders questionnaire that talks about, so it's called an MDQ, which can talk about the different symptoms of mania. And then if you guys look up DSM-5 questionnaires, the DSM website actually has lots of free questionnaires based on the DSM-5 diagnosis, and some of which I've actually been using because they're pretty straightforward and user-friendly. So that's just a couple of thoughts, and I need to stop talking. So any cases? So Dr. Freda, do we have a case?
Yeah, but I think Casey has a question. Yeah.
So I had a patient recently, and she had a pretty significant complex history of mental illness and traumatic brain injury. And she told me that she could not be diagnosed with bipolar because the symptoms of TBI overlap too much with bipolar. So when I asked her about had she ever been diagnosed with bipolar, she said she couldn't be diagnosed because of the TBI. Is that good information she received or not so good information she received?
So that makes it more complex. When you have a medical issue going on, like a medical problem, it makes it more difficult to diagnose. I would like to know more about her. I would like to know what started first, if it was the TBI or the bipolar or the symptoms of bipolar. Because there are ways of kind of figuring it out. But if somebody comes out of nothing, like one time, and you see them and they just had a TBI and you don't know anything of their history, it might be very difficult to make some distinctions, like about certain symptoms.
Yeah, her TBI started when she was 5. And so she's just had a pretty significant delay in development and kind of her emotional EQ and her IQ and her disabilities for learning. And now she's pregnant for the 3rd time with a short interval pregnancy, and she's just really overwhelmed, and she's not taking any medications, even for seizures. And I think about her care.
Yeah, so maybe that's a good point, Sarah, that maybe her provider can call us and we can help the provider figure out what's going on with this patient, and help with the treatment of the patient, because I'm sure the patient is suffering,
Okay, thank you.
Sure. So I was wondering if anyone wants to talk about a case that they have and bring up a case, and we can discuss and we can help you think about it. I have a case, but I was wondering if any of you want to talk about their case.
Dr. Freda, you just let me know if you need me to pick on someone. I can do I'll do the hard work here, and I'll be a tough guy.
I mean, I have a case, but I feel very vulnerable bringing it to this group. I'm just going to be really open about that. Is that okay?
Yeah, please go ahead.
Okay. So I have a mother whom I've been working with for almost 2 years now. Her youngest child will be turning 3 in a few weeks here. And, the treatment process has been tricky. This is a person who has experienced complex trauma since she was 3 years old herself. And let's see. So her first pregnancy, though it was scary in terms of she received some information that she might have some pretty significant, her child might have some pretty significant birth defects. the child actually was born relatively healthy and they had an amazing like bonding experience. She didn't experience a whole lot of perinatal mood or anxiety issues. And so she, I mean, there's so many layers to this, but also deals with a lot of physical pain, pelvic pain, got pregnant with her second child, was immediately experiencing high levels of anxiety. You know, birth was, you know, relatively smooth, non-traumatic experience. But immediately like knew that she was struggling, started working with me at that time. We've seen really great movement at times. And then she will have an experience like she had a really traumatic experience where her older child almost drowned. So just, it seems like it's just like one thing after another. And then, you know, we'll get to a place of stabilization again, and then something else will happen. And so, you know, throughout this whole process, I've been kind of, you know, educating her about medications and kind of encouraging her to seek care in that, on that level. And she's very hesitant to seek care because her mother was a very like, raised her in a home that was very like natural and holistic, but like did not include a lot of medical care. But also like there was substances such as marijuana present a lot in her childhood. And so she just like really doesn't want any sort of anything. So fast forward, COVID happens. It was like the worst time she's had probably since she was a teenager. And finally was like, okay, I think I need some medication support, and got a prescription for, well, I encouraged her to talk to her doctor about, oh my gosh, I'm totally blanking on what she got a prescription for. I encouraged her to talk to him about sertraline, but oh my gosh, what are some of the other like brand names that might have been prescribed in the SSRI family?
Zoloft, Paxil, Lexapro, Celexa, but
Lexapro,
it's
thank
okay.
you.
Oh, okay.
So she received a prescription for Lexapro, thank you. And then like started doing the Google search of like things that happen when you're on Lexapro, and hasn't taken it. So I guess my question is like, how can I support this woman to get care that, you know, she needs? I think it would be hugely important. I think I see her, you know, I've had the opportunity to work with her so long. I'm seeing the impacts on her children, you know, of being untreated psychopharmacologically, and I'm concerned. So yeah, I'm not sure where to go with this at this point.
So I was wondering if anyone has any thoughts.
How does she do with the psycho ed about how her kiddos are being impacted?
She's very insightful and she's very aware of the impacts. And then she also often compares it to her own experiences, and certainly her children are doing better and having a much safer experience in life than she did. And so I think that is valuable, but also for me, it's hard to watch because I'm like, and yet like, I see that they could be even more, like they could be thriving even more probably with just a little bit more support.
Mm-hmm.
Good question though.
Is she open to like any like in-home support or any additional resources like that from the community?
Before COVID, I would say she probably would have been. I will say absolutely not now. This is a mom who was very, very isolated. She also struggles with immunoresponse stuff. I don't know exactly the medical term for that, but so yeah, no, they've been on serious lockdown for almost a year and a half now, which obviously is exacerbating, I think, a lot of the issues. She is starting to sort of move through that. They're vaccinated now, the adults are, so they're moving, you know, into a more freedom, I think, socially.
I would say that one of the things is that it's important that she establish a relationship with a doctor, you know, that will treat her. Because part of medication, it's not just the medication, you know, it's also the alliance with the doctor and feeling that you can trust your doctor and that they are doing in your best interest. So I think it's not just getting a medication in an isolated way. It's also who is giving it to you, how is it giving it to you, what information they give you, are they listening to you, you know? So I think all that is important.
Thank you for touching on that. That's actually been an issue. Her care provider, her primary care physician, and I can't remember exactly what care that she was getting from this person, but they left practice, and so she has been without that relationship that you're talking about, and I think that is a huge component to it. So if you're in Missoula and you know anybody that I could connect her with, that please send me a message, folks. But yeah, that is huge.
Yeah, and also it sounds like it has a difficult history in terms of like trauma, and that it's not that. I'm glad she's connected to you, you know. I think that's so important, because if she weren't, like, things might be very much in a different way for her. But yeah, she needs the information about medications to help her in that part, you know. But I think what you are doing is so important, because my struggle sometimes, and a lot of times, it's like people come and they just want a pill that will make them happier, and that's it, you know. Yeah. And they don't think about all the other work they have to do in psychotherapy. So I'm so glad she's connected with you and she's doing the work with you.
Yeah, she's been doing incredible work, and so I am hopeful for her. And I think if we can just get this one last little piece in place, it might be even better. Thank you for the space for that.
Darcy, you probably have thought about this because I think you know her, but Charlotte Creekmore came to mind in Missoula as a person who might be able to provide primary care, because she does have kind of a comfort with that more holistic natural medicine approach too. I don't know if she's full or taking patients right now, but
I think my understanding, that's a great thought, and I think personality wise they might fit well together. I don't think Charlotte takes her insurance.
Well, dang.
But I did just get some other recommendations in the chat, so that's super helpful. Thank you all.
Hey, and Darcy, I just want to thank you for presenting and being vulnerable. So again, no, I'm serious, because it's not easy to sit there and be like, oh, I don't know. But the truth is, it's like nobody knows everything, and it's awesome that you're able to do that. And it's supposed to be a safe space. So thanks for modeling.
Thanks for letting me practice and get more comfortable there.
Yeah, that's really, thank you for that, because it's more valuable if you bring your own cases. I can bring a lot of cases, but it doesn't have the same value that if we discuss your cases, you know? And, you know, in terms of medication, there are so many options, but as I said, the relationship is so important, because that will help with the compliance with the medication, you know? Any other comments? Anyone that wants to comment about, or any questions about this subject? Treatment of depression during pregnancy. There is so much to talk about, and I'm sorry it was short. I have so much to tell you about, but like, if you want, you know, your providers to call us, you know, I will be happy to help and help them with the decision of what medications to use, and give them all the data about what is safe, what is not so safe, and that. But what I guess my biggest point here is what I wanted to tell you is that for depression, there is no real antidepressant that is contraindicated in pregnancy, even though some might have a little bit more side effects or more risk than others, but there's nothing that is really contraindicated. So that's very important to know.
Well, wonderful. I think, I think we're there. And again, I just want to really thank to Dr. Freda for emphasizing something that comes up all the time when we're prescribing medications is people come up with 38 different things and reasons why not to take medication, and I have to remind them, well, guess what? There are side effects to depression too, right? So there's side effects to medication, there are side effects to depression. So either way, they're getting something, and that you're either going to get a pill or you're going to get a depression. And which one do you want to live with? So anyway, there are two sides to that, but thank you everyone for your time. Another great session.
Thank you. Thank you for being here.
Bye everyone. Have a great week.
Thank you.
Thank you.